Great. Thank you very much. Welcome, everybody. I'm Dr. Keith Martin, the Executive Director of the Consortium of Universities for Global Health here in a rainy December day in Washington, D.C. Welcome to CUGH's Virtual Global Health Week, and this is the first of the sessions we're having. This is a very exciting session. We have some experts dealing with one of the most neglected issues in global health. We are very pleased that you've chosen to join us to meet our speakers and ask them some very pointed questions at the end of their presentations. And what we hope that this will be a very interactive and engaging session where you'll be able to have a good to and fro on Q&A about the issue of corruption. And corruption is one of the most, as all of you know, one of the most neglected areas in global health. If you ask the question about who's paying and how much, where the resources are coming from in international development, often we talk about aid or official development assistance. And that discussion usually revolves around monies that are a lot, in the $200 billion plus area. But if the monies that we need to be able to advance the development goals that have been set out in the Sustainable Development Goals and in other places, those sums are paltry compared to what is actually required. So where's the money going to come from? And what we're going to talk about today is where those monies are coming from. Now, our guest speakers today and the panelists on this are three really outstanding people. In the order in which they will be speaking will be Zoe Mullen. Zoe is the editor of the Lancet Global Health based in London. Next will be Professor Dina Balabanova. Professor Balabanova is a long-standing global expert in the area of anti-corruption. She is a professor of health systems and policy at the London School of Hygiene and Tropical Medicine, and she is the co-chair of the Lancet Global Health Commission on Anti-Corruption in Health. And that's the root of what the genesis, in fact, of this particular session is all about. So we're very lucky to have Professor Balabanova here for the session. And joining her will be a co-commissioner on that particular Lancet Global Health Commission is Professor Eleanor Hutchinson. Professor Hutchinson is the Assistant Professor of Anthropology and Public Health in the Department of Global Health at the London School of Hygiene and Tropical Medicine, and she too has a broad and wide-ranging experience in dealing with anti-corruption. I'm not going to go and spend more time talking about their extensive bios. I encourage you to take a look at the work that they have done, and also, I hope at the end of this, be able to follow the Commission's work, which is going to be extremely important as we work together to deal with this neglected global health challenge. A few words. Corruption, as we know, comes in many forms, and most of you know about the economic corruption that happens at different levels. But also, there's also political corruption. And essentially, corruption is, in fact, the advancement and the engagement and utilization of initiatives that self-deal, that actually absorb and enable people to take funds through illegal means for themselves or their network and colleagues. But also this political corruption that enables individuals to actually amass power for their own use. And all of that is illegal, or at the very least, immoral. If you look at the sums of money we're talking about, sometimes I ask this question, I said, well, how much money do you think is lost every year in corruption? And the amounts are somewhere between minimum of 3.6 trillion, with a T, US dollars every single year. Now that's more than an order of magnitude larger than official development assistance. So if we want to find out where the money is, where it's going, and how to get it for development, so countries can use those funds for the public needs that their citizens want, that's the place we're going to find it. So what we're going to talk about today is about the commission and what it's going to be doing. But finally, a last word. Sometimes we talk about corruption and being in low-income countries, but corruption is ubiquitous. It affects every country, and it hurts those people who are most marginalized, those who are most disempowered the most. It's essentially theft and an undermining of the assets and resources that countries need to be able to deliver the public goods their citizens want. And that in a time like this, where countries are swimming in debt, where the amount of fiscal space that they have is very narrow to be able to use for new and emerging or existing challenges, it's ever more important, friends, that we actually deal with this challenge and deal with it now. So with that, I'm going to first turn it over to Zoe Mullen, and then Zoe's going to turn it over to Professor Balabanova, who will turn it over to Professor Hutchinson. And after that, we're going to have some questions and answers. So please, as you think through and listen to what they're going to say, please put your questions in the Q&A box, the chat box on the bottom, or in the Q&A, and we will be able to proceed. In the meantime, make sure you introduce yourself in the chat box, tell us who you are and where you're from. And with that, I'll turn it over to Zoe. Zoe, welcome, and thanks for joining us.
Thanks so much, Keith. Hello, everybody. It's great to be here as part of this, in fact, kicking off the Global Health Week at CUGH. So, yeah, we are really delighted to be seeing this commission get off the ground. I've been interested in the area of corruption, particularly in healthcare, for some years now, and approached Dina, I think probably two years ago, or maybe even more, about the idea of doing a Lancet style commission on anti-corruption. So commissions, for those of you who aren't aware of them, are sort of 25,000 word reports. They are usually a couple of years in the making. They are a large review, analysis, a call to action, roadmap, and they're designed to be sort of living, active documents. So this area is something that we were delighted to entice Dina and colleagues into doing a commission on, because as Keith said, actually. It's something we need to talk about. It's an area that I think has sort of everybody knows that it's happening, but nobody wants to talk about it. It's kind of a dirty word, and actually, just getting it out there and saying what the problem is half the battle, I think. And it is an issue that is global. It is not just an issue for low and middle income countries. You only had to look at the COVID-19 outbreak in the UK and the kind of political corruption that went on and financial corruption that went on there, and the problem of sort of tax havens in high income areas that are sort of repositories for diverted funds. So it is a global problem, and so we wanted it to be tackled on a global level, and we wanted it to be positive. So I think a lot of work has kind of looked at the problem, but we know that there are some ways that we can tackle it. It's difficult, it's really difficult, but the Commission, I hope, will be putting together some packages on how we can go about tackling it. So I think it will be very forward-looking, and as I said, hopefully have a sort of active afterlife that will be referred to into the future. So that's it from me, I think. But as I say, really excited to be following this through, to hear how it's going so far from the panelists, and without further ado, then let's hand over to Dina to kick it off. Thanks very much.
Thank you very much, everybody. I'm just going to try to switch to slideshow. I would like to first thank our hosts, the Consortium of Global Universities of Global Health, and Dr. Keith Martin, who is, of course, our commissioner. He's part of the inception of this commission. So we're very grateful for this opportunity to meet with the constituencies that you reach. This is really important, as I'll talk in a minute. So I would like to spend maybe about 10 minutes looking at proposing what we are proposing, what we are going to do. As we already discussed, we would like to do something different. We are not here to explain this is a big problem. We already have a lot of knowledge of corruption as a public health issue, But we are here to think about how do we change the debate? How do we move forward? What are the possible solutions? And it is a very positive message, something that we would like to catalyze groups around that. And that's why we are here. We are going to almost end up with inviting you all to get involved. I would like to say a little bit about why corruption is such a big problem. Many of you, so it's interesting when we talk to those who work in global health, very often we face a little bit of a challenge. We're told, well, isn't it all about money? If the ODA, the global assistance, and if the countries are able to use better their money to have better governance, then if they have better funded health system, everything will be fine and we will reduce corruption. However, we see that this is not the case. This is even countries that have increased health expenditure, that have increased coverage. For example, we did recently a paper on Eastern Europe countries with universal coverage, and corruption forms continue to persist, unfortunately. At the same time, we look also at the experience in Europe, and as Zoe said, there's been a lot of attention to what happened during COVID. However, we were visiting some of the countries 2 weeks ago, and I would say that we have a lot of other things that are not related to COVID. They think even the COVID type of corruption is distraction. There is a lot happening that's not looked at, even in high-income countries. So I would like to mention that we have very little understanding of the estimates of what is the cost of corruption to public health expenditure. This is one figure that we have from a detailed study, 26% of the public budget in Uganda. However, I'm looking at estimates from 7 to 40 or even to 60%. And the Commission, one of the big tasks will be to look at the burden and the cost of corruption. What we have done, we already know a number of things, and this is where the problem lies. The corruption has impact on mortality and morbidity. So there is a very clear link out there for corruption impacting on responses and outcomes, child mortality, maternal mortality. We know that corruption affects access to healthcare, and studies are showing that poor people pay more, poor people suffer more. So that corruption is regressive. Very wealthier groups are often shielded from that. However, not just at population level, corruption damages health systems. It damages investment. We don't get the same return on investment. There is, even in countries that have implemented the social insurance, something that is now recommended throughout the, say, African region, we see enormous amounts of corruption. In Europe, this is one of the biggest sources of corruption, which we're actually looking into right now. Fake facilities claiming from insurance fund. So that's the biggest type of corruption in the Netherlands. And I'm told amazing figure that the funds involved in this type of fraud, it's a bigger scale than that involved in drug trade. So we're talking about absolutely huge amounts. We're talking about something in Belgium, in Netherlands, in Germany, so across many countries, even countries that we think of as having good governance, such as Norway, Sweden, they even report this type of corruption. So it is something in the health system that gets damaged, and with the involvement of organized crime, you really see that there are cracks in the health system where we don't achieve the results as intended. So this, of course, affects progress to goals, and Keith already talked about figures. We hope to look at the different figures of impact. And as Zoe said, the reason I think we were able to persuade many stakeholders to have this commission is what happened during COVID. And I think this is not that it's something unique, it's actually still going on without COVID. However, this created a space, a policy space. At the moment, many of you may be following the UK inquiry into the COVID response. And some of the major, this is in the Parliament, which involves the major stakeholders taking stock of what happened. And corruption and fraud came as one of the biggest factors undermining the response. So corruption affects everybody. It's a massive proportion of people's taxes. So it creates VIP lanes. so-called, where suppliers were given contracts without due diligence, and this was justified by the need to act quickly. However, once this is created, this weakens the system and it doesn't stop after COVID. So that was really interesting. So it is something that affects everybody ongoing basis. But I think we have this commission today and this debate because of COVID and what happened. So corruption, we've known about this problem for many, many years, and there are many scholars, bodies of knowledge looking at this. However, it was only in 2023 where the UN General Assembly on universal health coverage announced that corruption is recognized as one of the most serious barriers to effective resource mobilization, allocation, and poverty eradication, progressing towards UHC, universal health coverage. So that's really made a difference. I think also in terms of the international debates, we saw the creation of the GNACTA, which is led by WHO. It's a network, a global network for accountability, transparency, and anti-corruption in health, which preceded this commission and helped to shape it. So this is an initiative with governments, with major donors, NGO representatives and population representatives. And it is asking the question, how do we safeguard the money? How do we ensure what we invest in the health system really reaches the poor and its objective? And it is something that I understand there was a lot about this on the whole World Health Assembly. So I think we have reached a situation where most of the actors in global health recognize corruption as a problem. It's not just about money, it's not just about rules, because people bypass the rules, but really looking at the reality and what can we do? What are these initiatives? At the same time, we are aware that it is often political decision, and corruption can come at a cost. Those involved in anti-corruption activity could be threatened. We see this in our engagement in Latin America, that people actually threaten with their life. And it's also political risk for many, but it's also used as political tools. In many countries, accusations of corruption are used to get rid of opponents. So we know that it is a very complex problem, and it's much beyond the health system. That's our biggest message, that we need to look more broadly of what can we do. So again, that's another opportunity for GNACTA. You could see a lot of resources there. I'm just flagging this so you're aware. But another thing that you could be involved also is we have a thematic working group at Health Systems Global looking at action on accountability and anti-corruption. Again, anybody can join. You don't need to be members. So that's another way to join us and to contribute to these debates. And the Commission is very much drawing on all these initiatives. We are doing what's called listening exercises right now. We're going to talk to regular people. We are talking to students. We're talking to young people, to people in very simple settings like markets or places where people congregate. We really want to hear the policymakers, but also the impact on people. And these are opportunities for you to get involved. So that's another, a lot of our teams have been active in the media, trying to, again, the same purpose, to hear, because this commission would like to be not just a report. This commission would like to form a movement and to really respond to issues which are close to people. So therefore, engagement through radio, through TV. So in Africa, we have had a lot of these initiatives led by our partners. So let me introduce the commission briefly. So we started with this. What is our vision? I already mentioned some of that, but clear articulation of the harms, what Zoe was encouraging us to do. We really need to take stock. Then we have to think about shifting the dial. We are not here to just say whose fault is that. A lot of the corruption has been about punishment, finding who is guilty and punishing. We are saying something different here. We are trying to find solutions, something that could help us address this intractable problem. We are going to look at multifaceted evidence. We are not just going to look at peer review papers. We are going to look at reports. We are going to work with investigative journalists, any experts people who have lived experience, who have worked at community level. So we are very open to different types of evidence, and we are trying to combine it in a rigorous and very kind of transparent manner. The evidence is important, what we consider as evidence. We are already knowing, although people ask us, what are these three things we can do for corruption? We are saying we cannot do that. We cannot give magic bullets. But what we can give is some sort of foundations and principle. If a country wants to implement anti-corruption strategy, how do you do? Then one of the biggest intentions of this commission is to bring together stakeholders from different disciplines. We were extremely interested to work with people who work in law enforcement, to connect to people who work in organizational management, in political economy. So as I said again, health system corruption is not just about the health system. We need to work at the societal level to bring all these institutions together. And our analysis shows that that's one of the reasons we think anti-corruption has not worked so far, because it has been in a silo, and working just through the health system, you cannot do much. So we are keen to create this platform and movement of people. We are not going to finish with this report. We would like to continue and really try to see what we can do and what we can offer and how to connect people. So this is just our kickoff commentary, which was published in July in the Lancet, where we state our main intentions, and you could access that. So just a very quick one around our conceptual framework. So our conceptual framework, we start with outcomes. We are really interested. So there are a lot of forms of corruption. It's a huge amount there. And a lot of it's not necessarily corruption, but it is informality. It's the way people do business. So we're not trying to do everything. It's only a start. However, what we want to say is corruption. The biggest problem is that corruption harms health. So we start with the outcomes. We want to understand what is it, what are the pathways through which corruption affects health, financial protection, equity, and institutions. The reason we want to ask that, because we want to ask how can we address that? And we are saying that the way to address that, you can't do it by just putting a law and putting a regulatory framework. You have to change incentives. You have to make the actors keen to and willing. Something should be there for them and they to be involved in anti-corruption action. And that is possible to do. Reduce the opportunity for corruption. So in the health system, there are a lot of, we find that sometimes there are really simple things that could be done that could reduce the chance of corruption. And then, of course, all these organized groups, sometimes it's difficult to get involved if you make it too difficult. So I think a lot can be done in that area. At the same time, checks and balances, so create really opportunity for quickly acting on corruption. We know a lot of cases where corrupt cases take years to go into court. This should not be the case. There should be a different way of doing that. At the same time, we are very aware, and this only came up through the discussions of the Commission, the social norms, the way people rationalize corruption. There are many settings where people just say, that's how things are. That's all we know. That's what you need to do. There is a system of patronage. If you want to survive, if you want to get care for your loved ones, you have to do this. So I think we are looking to ways in which this narrative could be changed. And we are getting some very interesting initial ideas where people have done small-scale experiments. So that's our framework. We really want to focus on the harm of corruption. So what we've been doing in the past year, we did start on outcomes. We commissioned several reviews. We've been working as a team to look at the evidence. So let me just give you a snapshot. I'm not going to go through all of that, but I just want to tell you, because a lot of we've had many situations where people ask us, how does exactly corruption affect? How can you separate the impact of corruption from just a weak health system? So we've looked at that very specifically, only identifying studies that have shown a clear link. So these are the main types we identified, from a very big umbrella review, which is for publication now. But so these are the main areas. We see a lot of substandard falsified antimalarials that came as a big chunk. And of course, what you see here is biased because it's only what's published. We're looking at the moment at the broader literature, but this is based on what's published. We see a lot of economic impact of such and quality of care. absenteeism, access to quality of care, that's the impact of how the study look at it. Theft, diversion of resources, this leads to economic impacts. And it's all, so we link to how it affects individuals and institutions. So this is I wanted, because what I showed you before is the big themes, but let me bring one or two examples of concrete cases. For example, nurses absenteeism in Kenya was shown to be reducing the antenatal care prevalence and access to that. So we see a lot of informal payments that are affecting the poorest people. So substandard drugs, the global burden is between 10 million and 200 million. So we have a lot of very detailed, very granular studies showing the impact of corruption. So there is no doubt that that's the case. So we're doing a few additional analysis that link corruption to outcomes, for example, NCD, and we adjust for wealth of the country, for strength of the health system, and still we see a very strong link to outcomes. This is just as a concluding to this outcome bit. We have had multiple teams reviewing different bodies of evidence, and we see the same. And for example, that was interesting from Gaitonde, infant, and this is confirmed in more recent studies. Infant and child mortality are almost twice as high in countries with high corruption indices, have low immunization rate, lower use of public health clinic, delays to treatment. So it is really corruption kills. I think that's our conclusion so far. So the question is, where do we start? We try to create this matrix, and maybe it's not very clear, but what we try to say, okay, we need to start from prioritize for policymakers forms which are the most harmful, but also they are illegal, because there are things that are harmful, but they're legal. So we were almost thinking of priority. Of course, everything is important, but what is a high priority? So something that's extremely damaging and virtually could trace the outcomes very clearly to poor health and inequality. Maybe that should be a priority. So what the Lancet Commission is trying to do is also to show a pathway, to show how can policymakers act and where and what, not just what interventions, but where do they start? This is something we're going to be working at, because we want to give a roadmap. We want to equip policymakers with tools. So I would like to hand over now to my colleague Eleanor to lead us through the Commission approach.
Thank you, Dina. Next slide. Great. So you've heard a whole sort of range of countries that we're going to be looking at, a range of practices, a range of impacts that these practices have on the health system, on health outcomes. And so what we do when we start sort of thinking about definitions is try to sort of narrow things down conceptually so that we can start making links across these practices and start making sense of how they connect with one another. So those of you who have studied corruption or who have looked at sort of documents about corruption will be very aware of the Transparency International definition, which is very pithy: the abuse of entrusted power for private gain. Talks about power. It's a very useful definition. But as we were thinking about what happens in health and the range of impacts of corruption in health, the sort of complexity of it, we proposed, after Gaitonde, who said he didn't think the abuse of entrusted power for private gain was really fit for purpose necessarily in the field of health, that we needed to think about something in a slightly different way. So we came up with this definition, which is, again, the abuse or complicity in abuse of position, power, or authority. So we expanded this idea of power to materially benefit an individual or a group of people, because we know that people often work in groups together when corruption is underway. We certainly saw this in the UK, the VIP lane, for example, for COVID contracts was definitely a sort of a group of people. Social relationships were really important in that. to materially benefit yourself or a group in a way which diverts institutions from their core aims. So this refers then back to Dina's slide, where we are particularly concerned with the way in which corruption impacts on the health system, because we're concerned with the way in which it impacts on health outcomes. So keep this in mind. It's about, we're concerned with forms of corruption that divert institutions from their core aim and undermine them. Next slide. So as you start thinking about the slightly more sort of complex definition of corruption, if you like, what it shows, I think, is, that health systems don't operate in isolation. Health systems are social institutions, and they are embedded in an economic, in a political, in a socio-cultural space or sphere. All of our health systems are impacted on those forms of power, on those connections, on those forms of practice that come right into the health system and shape practice there. And of course, crises and emergencies that appear shift and change and shake up the way in which care is delivered and the type of care that we need to deliver. So the first thing to sort of think about is the fact that health systems don't operate in isolation. They're social institutions, and all of these other factors in society come in and shape what is happening in the health system, and that includes what is happening in terms of health sector corruption. You may find, for example, that the rules that really matter in a particular society, or the rules that really matter at a particular moment, are absolutely not those that are written down in policy, that they are secondary to the informal rules that have emerged amongst different groups of people and powerfully drive behavior and practice. Next slide, please. And once you start sort of thinking about health systems corruption, the entire health system, something really sort of, I think, then started to shift, definitely with the work that Dina and I have been doing over a number of years, in terms of sort of challenging how we think about corruption. So when we think about the sort of usual parlance of corruption that we have in society, very often we are thinking about immoral individuals who are gaming the system very strategically. So we focus on corruption and moral failings. And often we think about the fact that if it's just to do with this one sort of individual who is just trying to game the system for themselves, then we fail to look at other things. And quite often then, if we think about it as a moral failing, we think, well, we just need to reinforce the rules again and again and again. And then we also sort of extend what happens to anti-corruption activity, where we think, okay, let's clamp down on corruption across every part of society that we can to target these immoral individuals. But that's not the story we're trying to tell in this Lancet Commission and in the work that we're doing. What we want to do is shift away from discourse and focus on the failing of particular individuals towards instead understanding what is it about the institutions and the structures that we've got in society that create these root causes, that create space for corruption, and sometimes make it appear very logical that you rely on informal rules, which then again, as we know from the work that we've done, the reliance on informal rather than formal rules opens this space for corruption in whichever country it's working in. So we really also want to think about these informal domains. Yeah, what are the beliefs, the norms, the incentives, the networks that shape practice? Again, if you think about that diagram of the health system with all of these sort of different networks of practice, you have to think about what's happening in those different spheres of society and how that's shaping practice, in terms of my interest, right at the front line of care, but across the health system in different ways. So we know then that there are causes beyond the health sector, and we have to engage with that. We cannot be afraid, as people working in health and working in public health, we cannot be afraid of understanding the broader political economy in a society. In fact, we absolutely have to understand that. We have to understand socio-cultural institutions and networks as well. So we understand then this is our health systems approach. It's the health system as a complex social institution, as a complex social system. We have to understand informality. Ask yourself, which rules matter and what are they opening space to do, and understand in detail the incentives of different actors. And then finally, we don't need to wait until corruption appears, but we need to think, once we start thinking about the institutional and the structural root causes rather than immoral individuals, then we actually have much more space to think of preventive measures as well as remedial measures. Next slide, please. But it's complex. Yeah, how on earth do you then really start thinking about what we need to do, what sort of anti-corruption strategies that we need? Where do we start? And I ask the question, where do we start? With our understanding in mind of the difficulties of acting on corruption across different settings and the enormous amount of work that is currently going on across sectors, actually, to try to understand anti-corruption strategies that will work, and as Dina often reminds me, will work in the long term. That you may be able to get an anti-corruption strategy that works very short term, but people find their ways around it quite quickly unless you put in place, the right sort of strategies that can work really over years and years rather than over a few months. So what are the fundamental preconditions? So those of you who are engaged in the world of anti-corruption may have heard quite a lot of criticism about transparency and accountability approaches. We hear very frequently, it's not enough. It's not enough to put into place a new accountability approach if there's no one in a society who is able to enforce it. So we agree with that. We agree that it's not enough, but they absolutely have to be there. You have to have a transparency and accountability approach as a way of starting and working. It also does, what Zoe talked about, what Dina and I have talked about very often, is it starts the conversation. Yes, we need transparency and accountability approaches in place because we need people to start talking about corruption and anti-corruption in health systems. So we also need to think about anti-corruption over time. Yeah. What is amenable to change in the short term and what is amenable to change in the medium term is a really good sort of question to ask, and a question to ask of policymakers. So one of the things that we've done in the work that we've done and that others have done that I think has been much more successful, much more realistic place to start is to talk to policymakers, to talk to people delivering care at the front line and say, what is amenable to change here? What is it that you think you can change to make these gains in the short term and in the medium term, to create what we can term islands of integrity, places where the formal rules can kick into gear and can protect people from informal payments, can stop so much absenteeism in a health system. So you also need to ask then, who can be incentivized to act? Who are the people engaged in corruption and who are the people who are not? Who are the health workers who are going to work very regularly, day to day, when other colleagues are not going to work? Who are they? Do they have power? And who is interested in stamping out corruption in a political setting? Who has the power to ensure that other people step up and abide by the rules? And often these people are not in the health system. That's why we say that you need to take a broader approach and think of others. You need to think of who then will benefit from anti-corruption, and you need to connect with those people and you need to support those people. And then we have to think about the way in which it can shift and change power. So running through all of this, I guess one of the key themes in running through all of this work is thinking about power and finding ways to act on power, both to stamp out corruption, but also people who are powerful, who have an interest in supporting anti-corruption. Next slide, please. Okay, so then just thinking briefly, I've talked about, the different sort of timelines that you can think of when you're thinking of anti-corruption strategies. It's very important to think of wins here and now. We know that if people start talking about corruption in some settings and you don't have an anti-corruption strategy in place to try and act on it, it may have a detrimental impact. So if you talk about corruption being very widespread, what you may end up doing is making it more acceptable in society. Oh, everyone's doing it. There's corruption everywhere. We can't act on it. We don't know what to do with it. So if you're talking about corruption, also talk about anti-corruption and make sure you've got a strategy that is in place going forward. Then think about medium-term strategies. Can you draw on political consensus? Can you create some strategic compromises? Can you create, and this is particularly important in health, can you create investment priorities that are going to deliver care and act on corruption, so allow for funds to be delivered more effectively. And I think mainstreaming, I think we may have got to a point where mainstreaming anti-corruption into any type of health sector reform is something that we really need to campaign to make sure is there. And then finally, we of course need to link to long-term visions for health system strengthening, to have frameworks that respond to shocks or crises and have embedded in them an anti-corruption strategy. That we know when we have, for example, in the UK, years of austerity, underfunding, so that we don't have the crisis response in place, plus particular types of political actors, that we can have a crisis of corruption at the same time that we have a crisis in terms of health. So let's think about the social contract and think about the political vision as you consider these longer term strategies. Thank you.
Wonderful. Thank you.
Thank you very much. So back to me, would like to just tell you 2, 3 things about how exactly. So we showed you the complexity, we show you the scale of the problem. The question is, how do we go about it? And I think I just want to show you in 2, 3 slides. So I'll be virtually 2 minutes before I'm very keen to move to the discussion, but just to show you what we're going to be doing in practice. So what we decided is to split our commissioners, but also experts. We're going to involve experts on a particular topic. We are very keen to involve people from outside the usual silos. We're going to go and really find such people with knowledge and expertise. We're going to split ourselves into 6 working groups. So the first 3 are the outcomes of corruption. I already showed you, we are working very hard on amassing the evidence, but really trying to understand the magnitude and the pathways, and because that would inform what strategies address which part of the pathway. Are we improving access, or are we looking at actually some other disadvantage where certain people are more susceptible? So that's where we have to really look at how these outcomes manifested. Then we're going to have a group, maybe a shorter group, looking at why have the existing anti-corruption approaches failed. We really need to understand, because there's been enormous amount of investment and people working on this in health, and we know that a lot of things have been done, but maybe the impact has not been as expected. So we would like to look at that and try to examine, take stock and learn from that. Then what Elena was talking about, the institutions, like focusing on institutions and trying to understand how do institutions, the different types of institutions, enable corruption? What is it in the makeup of the way the institutions work, different sectors, or could play a role? We also looking from the positive aspect of what, and this is one of the things from India, for example, we're hearing the national auditors, they work beyond health, but they're extremely important and they have a lot of capacity to look at some of the issues in the health system. These are the type of things we want to identify, good examples of where institutions can change and address corruption. And then the other 3 are people. We want to look at why are people in institutions corrupt. So we are starting to look at philosophy, we're looking at law, legal frameworks, anthropology, behavioral science, sociology. So we're just looking at, we don't believe people are inherently corrupt. We think some sort of circumstances trigger behavior and incentives. So as I said, this is part of our thinking. What are the incentives that push certain people in certain circumstances become corrupt? That's our question. We're going to look at a lot of disciplines. Then we're going to, of course, to look at the politics. Many of you talked about politics, and Keith introduced with this. But we do have to, so we know that corruption is not always linked to exactly political regime. We know certain regimes who may be more autocratic, but they've done good on corruptions, but other situations where it's the opposite. So what we are looking at, what are these mechanisms, political mechanisms that have enabled successful measures, and how can we replicate that? How can we learn from it? What are the fundamental principles? The final thing is which I talked about, the narratives. We know that the same way as you could create fake news and create fear, create hopelessness. And we actually are looking at there is impact on mental health. People don't want to get involved in collective action because they don't believe it's possible. They have hopelessness and fatalism. But you could reverse that. People are doing experiments looking at how showing these short-term wins, which Eleanor talked about, could actually change the view. They could energize people and create opportunity, but it's short-term. So we want to look at how do we change the narrative? How do we convince people that they can act and anybody can act? So finally, where you come in, and that's our offer in a way during the discussion, we can think about. We have the commissioner, we have Zoe, the Lancet editor, the Lancet Global Health editor, but then we also have the technical team at London CUGH in tropical medicine working closely with our commissioners and coordinating. But we are constantly doing this engagement with global health practitioners, with members of the public, with people who want to say something. We are tracking that. We are trying to engage in many different ways, and we would very much welcome the discussion today and further involvement in different ways. And finally, I would like to just show that Lancet Global Health, of course, publishes rigorous analytical work. We have to have evidence. We have to have strong, clear outputs and provable, because we may be attacked in a sense. There are always those who want to minimize that or saying your data are not precise. So I think we are very clear that we want to be evidence-based. At the same time, this needs to be together with policy engagement, because we have quite a big ambition to make a difference beyond that and create a platform for further exchange of information and supporting countries who are starting to implement anti-corruption strategies. So with this, I would like to hand over to Keith, and thank you very much for your attention. And I'll stop sharing.
Fantastic. That was wonderful. Thank you, Dina. Thank you, Eleanor. Thank you, Zoe. So now we're going to go to question and answer, and you'll see a Q&A in the bottom. Some of you have put in questions. Please continue to do so. A couple of shout outs. Number one, as was mentioned earlier, this was, by Zoe mentioned, this is the first of our virtual Global Health Week. We have 16 sessions this week. You can go to CUGH.org. So I encourage you to sign up for others that you are interested in. All are free and open to all. With that, I'd like to ask Dina first a question on where you just left off, because one of the questioners asked how they can contribute to the commission. Perhaps you'd like to expand on that and just maybe also start at the end. You mentioned a platform. Where do you see that going? Because this commission is going to have life after it actually ends and delivers its report, right? Could you perhaps expand on both of those, how people can contribute to it, and then the life of the commission after it's born?
So I will, I think after we have the emails of everybody, we will send a place or somebody where you could contribute your thoughts. But that's something that we are at the moment working on. Maybe it will be something via LinkedIn, because we are first, there are two aspects. There are people who just want to share their experience of what is it to live in a corrupt place for any setting, and what have they tried and worked or not worked. I can see in the question here, you have a great idea for solution to a really pervasive problem. We want to capture that. We are very interested to capture that. And in our thematic working group, which I showed earlier, that's another way to be involved. We actually had a blog competition, people writing blogs about successful practices. So we have multiple ways, and I think what we need to do is to put them in one place, because we need to start learning from that. But we are going to have another way to get involved via this platform. For example, that would be if somebody flags a solution, we could have a discussion. What are the unintended consequences? What are the possible issues? Because nobody has the only answer. The evidence on anti-corruption solutions is extremely sparse. We're actually looking at other sectors. So this would come, and very much, if you want to stay in touch, please notify the organizers. And maybe, Elizabeth, you could put the email where people can get in touch, or I can put an email of one of our colleagues who is collecting all this. But yes, we would like to create a platform and something on LinkedIn. We're going to have, as the working groups work, I think we're going to have periodic engagements via LinkedIn but we'll continue also with country engagement. So if you want in your country setting to organize a meeting, or if you want to talk about some of these corruption issues, we can invite some of our partners who are in the same country, or one of us can join them. So there are many ways. Thank you for your interest.
Thank you, Dina. And that's a nice lead up to Eleanor to your question. Then, Zoe, I'm going to ask you a question after this. But Eleanor, one of the questioners works in a Ministry of Health and lamented the fact that a number of contracts are actually given to people perhaps favored by the ministry, not based on merit. And these consultants do work that's substandard and subpar. So perhaps you could talk a little bit about the importance of what can individuals do in that case, and the importance of building and strengthening the public service across ministries. Because you mentioned the important issue, laws are not enough. You have to have an enforcement mechanism. And sometimes that capacity in the enforcement sector of this equation is wanting. So maybe you could just extrapolate on that as per your comments.
Thank you. I think that's a really good question. And actually, I think it also ties into what Dina was saying earlier about the fact that I think what we probably will end up with, working on the Lancet Commission are a sort of not a series of solutions, but a sort of process of thinking about the problem and the problem at hand. So firstly, I think what's really useful about this question is it's something very specific. And I think that is where we've got to in research on corruption by thinking about anti-corruption, that we're not looking for a whole sector-wide response. We're looking at something quite specific. And so actually trying to tackle a very particular area, I think, is important. And what you are looking for, I think, in this, so what you may be looking for is, are any of the rules in place? Is it that with this sort of practice that you actually don't have any forms of accountability and transparency that would be in place, so that actually this person isn't really breaking the rules, they're just sort of gaming the system. So you'd want to see, are the rules in place, and are there formal rules in place through which you might start tackling the problem? The second thing then is about how you enforce these rules, and this is where you then need to start looking at whose interest it is to enforce the rules. And what sort of power base those people might have. So what you want is a coalition, and it doesn't have to be a coalition of people. Very often I think when we think about sort of collective action in health, we're thinking about sort of communities coming together, but this can equally be civil servants coming together. There are people who argue for the fact that what you are really looking for is a very one or two powerful actors whose interest it is in to enact a form of anti-corruption. So someone who is finding it very difficult because these consultants are being contracted, they are making problems for people further upstream because they're not doing their work properly, or because they're associated with, with a particular group who are coming in and rent seeking more generally across the civil service, so making it hard for people. And what you want to do is build that group of people, hopefully with some powerful actors in there who have the possibility of enforcing rules that are in place. So it's about being very strategic then, I think, about creating these networks, but you need a really good understanding of what it is that is underpinning this practice in the first place.
Thank you very much. Thank you very much, Eleanor. And that leads to Zoe. You're the editor of the Lancet Global Health. You have been a wonderful collaborator, partner, supporter of the work we do here at CUGH. We're extremely grateful for, and being an ex officio member of our board. You've had a lot of commissions go through, not only yours, but also the Lancet. We've had these discussions in the past, and also I think with Richard. If you're looking into the future, how do you think commissions can be best used or crafted to be most effective and impactful to deal with some contemporary challenges? Because this is a big contemporary challenge, as we all know. What's your aspiration for this commission?
Yeah, thanks, Keith. I think, I tried to kind of summarize what a commission is supposed to be like in my introduction, and I think the key is that there has to be something actionable about them. I mean, the best commissions that I've seen that are most impactful have they do come up with some kind of a kind of eye-catching figures often for how a certain burden of something is affecting people's lives. And so in this case, I think the work around kind of putting a number on the impact of corruption will be important in order to just grab people's attention and to focus on just how much of a problem this is. The second is obviously to come up with some actionable solutions that are involve the very people that need to enact them. So the best commissions, like Dina has outlined, include a, a wide range of stakeholders in the whole process that goes forward. So that it's well informed and that the solutions that are suggested are appropriate to various levels of stakeholder in the system. And we know this is a particularly complex system that involves many different levels of the health system and well beyond and into society, as we've talked about. So a commission has to reflect on all of that. I think actually going back to one of the questions from the audience, having case studies from countries, just showing how they do affect real people is important. Some of our commissions have had um, uh, uh, you know, statements from people with lived experience of a condition, or in this case, an act of corruption. Perhaps those are very powerful personal statements of how they've been affected by the issue. Um, and I think, yeah, building a platform into the future that will mean that it's a living document that can be acted on. Having the commissioners themselves and the advisors and anybody else who's interested to actually take the work of the commission, contextualize it in their own country, hold workshops, kind of almost give it a life of its own, in different country settings. Those are the sorts of commissions I think that can be very impactful. Yeah, I've got good high hopes for this one.
Great.
Maybe,
Thanks.
maybe Keith, I can add to this.
Please, Dina. Yeah.
Thank you, Zoe. This was really great. I think from somebody who is looking from outside the Lancet Global Health, what is a commission? Why did we think commission would make a difference? Everybody knows the Lancet commissions. When you say Lancet commission on something, people really know it. That's almost like a shortcut to explaining what is the logic. So it is a fantastic way to, for example, I remember when the Lancet Global Health Commission on Quality, led by Margaret Crook, came, it was a massive impact because everybody would say the word quality. Oh, yes, the commission said these three things. It is incredibly important in terms of opening up policy space. And the way I think we see the commission, not as just one commission, this is our team. I see it as a network. I see it as a network with other organizations that work on this. And that's what we have been doing, connecting to those groups and various country level, also trying to reach to, one of the questions was disadvantaged, really trying to reach to NGOs, to kind of groupings that work with such populations. So we see each other as part of this network with common objective to do something that improves the outcomes and life of normal people when using the health system. I think that's our objective, but it is our network. So in a way, I see the Lancet Commission as a way to catalyze action because it's all known. It's a way to convince people to work together and to get them together. That's, I think, one of the biggest advantages of such a commission.
Thank you. Thank you very much, Dina and Zoe. And just on the follow-up on that, one of the questions is related to those who are most affected are those who are most disempowered. And it ties to another question, which is about the political undertones of all of this. If I just can say one thing, though, oftentimes we talk about corruption within the context of low-income countries, but those monies are being laundered through high-income countries. They're deposited in high-income countries. They use high-income countries, our countries' financial systems. They're deposited in our assets, our real estate, cryptocurrency. So if you pointed a finger at at lower income countries saying that's their problem, three fingers are pointing back at us. So we need to be able to do that. And I think one of the things that we have an opportunity in this particular commission is to actually proffer solutions that can be deployed in high income country and low income countries. I think what we've heard is that's an aspiration here. And so a question I have, Dina, for you is a really an important one. We know that a lot of the people who are most affected can sometimes be threatened in including their lives. How can we, through this commission, be able to offer some solutions and some mechanisms on how they can actually share how corruption is affected by them and enable them to act at any level to be able to address corrupt practices and change the systems that are allowing this to happen while ensuring that they're being protected? It's a tough question because the actors can be pretty venal and brutal and violent.
Absolutely. So this became clear to me recently, talking to investigators from Holland, who were saying that they've not even come across one single case of corruption where there was no organized crime or very powerful network. So we're not talking just about people being attacked in their job. We're talking about lives. And that came up in a lot of the country level discussions. Of course, we don't have clear answer. We only academics here trying to get together the evidence. But I think that's why working with law enforcement agencies and anti-corruption agencies at country level, it's so powerful because we work with some of them and they sometimes say, we wish we have a broader platform and reach to the health sector because they seem to work in silos. I think if there is a better linkage between different agencies, that would make it clear because very often they suggest some solutions in there. For example, protection of whistleblowers is a very big thing. And I remember when I was attending in the parliament hearing about the COVID inquiry, one of the former heads of the anti-fraud office said, this is one of our biggest failures. We have never managed to establish protection in the UK for the whistleblower. So what can we say? This is what we hear again and again. And I think the more agencies you involve, it has to be multi-agency issue because it's not just the health system. It is something that when people are attacked, very often this is from entities outside the health sector. So even with contracts, with procurement, it may seem quite specific to the health sector, but actually it is not. It is run by forces outside who are very powerful and they know how to game the system. So I hope we can just start this conversation and go somewhere from there.
Oh, go ahead, Zoe, please.
Yeah, I mean, this is just a suggestion from me, and I think it goes back to what Eleanor, I think, was saying about not trying to just point the finger at people and say these people are bad. People who are told that they're bad, and you're going to take something away from them because they've got hold of it by illegal or immoral means, will fight back. So maybe, that in focusing on the solutions, we should be thinking about the benefits of anti-corruption work for everyone, becoming a more transparent political operator, becoming a more trustworthy political operator. What are the benefits to that person and to that community of individuals? I think this is maybe one of the ways we can help to kind of neutralize the sort of combative tone. I think that maybe some of the anti-corruption work can take. What can we all benefit from anti-corruption, including the perpetrators, maybe.
Well, that's great point.
Just to mention one of our team members, I totally agree. So I think this is really important. One of our colleagues from Nigeria, he's a psychologist and he's looking at approaches which are like restorative justice or where people are put together. And because we believe in our studies of corruption, very often, even people who get into very serious fraud, very often it is disadvantages or lack of there are issues, pressures, and it's not always the case, but there are lots of cases where things could be resolved at community level. So we've been looking at some of these positive approaches. There are limits to those. And one person asked about political intervention. I would say one of our groups will look at that. One of our big worries is if you look at the elections in a lot of countries, a lot of them are about anti-corruption. This is a big election slogan. It seems to be universal. High, low income, lots of different countries. But very often it is a slogan. It is not real. It is only to get rid of people or to create some sort of invasive laws, which are so corruption is used as a screen to do something. So I think the group on the politics will be really busy trying to figure out what has worked in terms of are there any positive approaches we can learn.
Thank you. Thank you very much, Zoe and Dina. And Eleanor, along those lines, first of all, thank you very much, Dina, for putting Elizabeth, who's producing this and doing a great job and on our team. She put into the chat the emails of Preslava and Dina. Just a big shout out to Preslava for the support she's giving to the commission. She's doing outstanding work. Preslava, thank you very much. So for those of you who are asking questions on how you can contribute or thoughts that you have after this, please email Preslava and Dina with regard to your contributions and suggestions for the commission. Eleanor, along the lines of what's just been mentioned, on the political side, how can politicians, how do you see this commission engaging both the public and politicians? And also, as Dr. Mashalaba mentioned, who's one of the wonderful environmental One Health scientists who work with us in many spheres, she asked the question about non-medical disciplines being involved in this, and she works with a lot of veterinarians, people in the animal health space. Can you share whether the commission is open to having non medical, human medical people involved in this effort, and how the commission can engage with the public in this effort during its creation, during its final report, but also after that?
Okay, I think that's three questions in one. So I think when we think about engaging the public, we will be doing webinars like this. I think one of the things that's very interesting about anti-corruption is that it draws people into public health who are not necessarily interested in it. They wouldn't come to a normal public health webinar or seminar, but they might come to one where we're talking about corruption, anti-corruption in particular, in countries that Dina and I have worked in. But we also work with a whole network of researchers who have this, how on earth do we engage the public in these discussions in the first place, and have been working with that problem for a number of years. So it depends where you work in the world, but we know, for example, colleagues in Nigeria who seem to be constantly on phone-in programs, radio programs, talking to people, doing exactly what Zoe said needs to be done. Tell us about your experiences. Tell us about what happens to you. Tell us about what happens when you go to a health centre and there's no one there, or you're asked to pay an informal payment, or a relative of yours is asked to pay an informal payment. We have the same radio programs. I don't know we discussing the COVID inquiry and what happened there in the UK. So I think there are these public debates that we can tap into that are happening in countries already. So I think that's the first point. Non-medical disciplines. So I think absolutely when we think about problems like antimicrobial resistance, there was an excellent paper that linked corruption. Dina, I think we haven't read that for a while, but I remember when we were working on it, that was one of the very few papers that had started trying to sort of make these links between what happens in countries with high level of corruption. Can we link that to AMR? Are there other forms of sort of we might want to call rule breaking around medicine use that are happening and that might be connected? So I think absolutely thinking about the connections between different disciplines. You'll notice that in a lot of our slides, there were sort of networks or ideas of how these flows impact on one another. I think that's incredibly important. But as Dina showed, so not just thinking about, veterinarians and medics, for example, but thinking across the health system of, different people differently situated in the health system, and then philosophers and anthropologists and legal experts also bringing their perspectives in. And then finally, there was a question then that you posed about politicians. I think we have to be very aware. So one of the things we look at is the discourse of corruption and how it's used. Yeah, how are people using language about corruption? What are they doing? And perhaps one of the things that will mark out politicians who are using the corruption discourse just to batter their opponents to those who want to do something about it is actually through the sort of discussion we want to promote of the Lancet Commission, which is, okay, let's talk about sensible anti-corruption strategies. And if you are a politician talking about corruption, if you're a politician talking about anti-corruption, that maybe actually we can trust your narrative better and we can trust your discourse better. And those are the politicians that we should be engaging with.
And part of that to your question, to your response, should I say, Eleanor, is in the way in which we communicate. So, Zoe, I wonder if you've given some thoughts as to how commissions can be in this fractured communications environment that we live in today in the 21st century. Have you given any thoughts about how commissions can actually communicate their work in a manner that's more effective to the public? Given that we're looking at sound bites that are sub 7 seconds, that visual stories matter the most perhaps, and that we have to not only appeal to people's brain, but also perhaps even more importantly, their heart and evoke emotions. Any thoughts about how commissions can actually communicate their work most effectively in this moment?
Yeah, that's a great question, and I think it's something that all publishers are having to think about. How do we in this environment where there's such a diversity of information sources, where once you just relied on, if you were in the UK, you watched the BBC for your news, and people who were medically trained would pay to read the Lancet, and that nobody else would read it. Now the Lancet Global Health is an open access journal, which means that anybody can read any of the content. So this commission will be completely free to read in its entirety to anybody. But will it make any sense to them? That's the very good question. And so now we're having to think about how we work in this open data environment. It has enormous advantages, but it also has downfalls, because any part of the text could be taken completely out of context and used in a 7-second soundbite, in the wrong way. So we're now having to think carefully about how to work with organizations like Sense About Science, which is a UK-based organization which works with experts and journalists to interpret complex scientific and health policy related work in a way that, especially if it's a slightly controversial area, that the public will understand in the way that it was intended, and not be taken in out of context or distorted or converted into misinformation. We offer a number of different routes that people can dip into. Normally, we've done podcasts with our commissions, so this is a way that a lot of people are getting their content now about all types of matters, not just health or news matters. So we do those. So we may well invite Dina and some of the other commissioners towards the end to get involved in a short podcast to describe some of the work in a more approachable way. We can also do infographics, which are useful for sharing on social media. So you can kind of use a visual graphic format to kind of portray some of the key messages of the commission. But also, we can have, for our last commission that we published on medical oxygen security, we had a number of these testimonials from people who were affected by video. So they had recorded videos of themselves talking about how they'd been affected by lack of oxygen during the COVID pandemic. And so this is something that we could do with some of these real life cases. We could do it by video potentially. So So there are lots of different ways we can use different media types to get it out there, but there's no doubt it's a really, really thorny issue that is always evolving.
Thanks, Zoe. And Dina, before we I'm going to go to some last words, and we'll go in reverse order. It'll be um, Eleanor and Dina, Zoe, and finally myself. Um, Dina, you've been working in the space for a very long time. You've seen the impact of corruption on people's lives. Put yourself in the shoes of that person who is working in an environment where they see corruption taking place, and they really would like to be able to do something about it. They may not know what to do or how to go about doing it. Can you share with us what your message to them is in this moment of time, what they could perhaps do now, even before the commission delivers its final report?
This is interesting, very important question, something that I think in our team talk frequently. And I think going back to what Zoe talked about, we're in a different situation. We are in a situation where, and this I would say to anybody, don't despair. There are loads of things that you can do now. And I would like to give an example with the several years ago, the Nigeria elections. There was a lot of discontent and people, a lot of young people commenting online and reporting various problems. It was incredible in the strength of this engagement. And there were even people who were saying, I live in a very remote place. This is what we experience. So I think if we were 20 years ago, I would have a different answer maybe. But now we're anybody, and some of these things go viral. It's really interesting. Anybody can do, not just reporting on media and social media, but doing something locally, talking to people, thinking in your community, who is the person who can make a difference. We found that, for example, in a lot of countries, it's not the people in the health system. It is the people who are, say, for example, local village chief. Even I was talking to a mayor in Holland who said, I started to be involved in that because I think we're losing huge amount of money for my population. So these are the people who can make a difference. That's what Eleanor talked about. Think who in your community, who, how can you talk to them? How can you engage? And why would they listen to you? Maybe there is a good moment in time. Maybe they're campaigning for something, but try to don't despair. I think that's our message out there, that there are a lot of things that could be done even now in your way. But this is only a hope that we have. And we've been spreading this message.
Yeah, that's great. That's what we need. We need hope plus action equals impact, in part. So I'm going to reverse in terms of last words, and then we'll have a quick close here. Before I do that, I'd just really like to thank Elizabeth Harani on our team here at CUGH, backed up by Sarah Kellogg, for their amazing work putting this together. And again, Praslava at the Commission for all of her support, supporting Dina and the rest of the commissioners. So I'll just go in reverse order, and then for final words, Eleanor, and then to you, Dina, then Zoe, and then I'll go last. Eleanor, please.
So very briefly, and to build on what Dina just said, actually, which is we often think about whistleblowers as people on their own, as individuals. And actually, if you're interested in anti-corruption, maybe what we need to end up with are networks of anti-corruption activists and of people sort of embedded in their communities, in the areas that they live in, who are all interested in this. That I think we recognize that corruption happens in networks, and perhaps what we need to do is recognize that actually anti-corruption also needs to happen in networks, and we can all be involved in that. And just to say thank you very much. It's been a real pleasure to be here.
Thanks so much, Eleanor. Please, Dina.
Thank you. Three things. Mainstream anti-corruption in any health policy. So I don't just work on corruption and governance. I work on other topics, non-communicable disease. I work on human resources. I would say in every single topic I work in, we come across corruption issues. and people are coming and saying we are having these issues. So it is everywhere. It's really should be mainstreamed when a new policy or policy design intervention is being implemented. At least ask the question, do an assessment. Are there any possible corruption? What can be done to prevent? Not everything can be prevented, but a lot can be prevented. Out mainstream. Second thing is create positive vibe and narrative. Create this global narrative that actually we can do a lot and publicize the good examples. People learn by learning from a positive, and that's really powerful. That's also shown in psychological experiments. So in behavioral science, I think we need to work more with these behavioral scientists because it is enabling. So people who are more positive and they feel something could be changed, they're more likely to join collective action to create this network, which Eleanor was talking about. And finally, I just wanted to thank you and to say this is not the end. We're going to flag a lot of our ideas. We're going to discuss them in various. So if you are interested, just email us and we'll let you know how to get involved.
Thank you very much, Gina. Yes, it's not the end, it's the end of the beginning. Zoe, please.
Thanks. I think similarly to what Dina was saying, I would just call on us all to and this came also in the commission that Dina mentioned earlier on quality in health systems. It's igniting demand from the communities for something better. In the Quality Commission, it was demanding better quality healthcare. Here, we're demanding a basic standard of decency and transparency from all the actors that we're involved with in the health system. So it's being positive, but it's also sort of saying, well, let's raise our expectations of what to expect. Let's not be fatalistic. Let's not say there's nothing we can do about it. This is just how it works. It can be better, and let's try and give there some momentum to that feeling that things can be better and they ought to be better.
Thank you very much, Zoe. And on the better side, on behalf of CUGH, let me invite all of you to come to Washington, D.C. next April 9th to the 12th. We will have our annual Global Health Conference, and it's going to be on the future of global health. You can register and learn more about it at CUGH2026.org. We certainly hope to see you there. And a couple of shout outs. Number one, I want to just thank Tom Burgess. He's the lead investigative reporter at the Financial Times, the author of The Looting Machine and other books. Just a thank you to him because he was part of the genesis of this effort, one of the seeds that started this a long time ago. So a big thank out to Tom. Check out his books, they're amazing. Also, check out Transparency International. They just came out with a new tracker on healthcare and corruption. And so I encourage you to take a look at that. It's really well done and it's very usable on the line of useful tools that we can take out and use today. Finally, on a positive note, corruption right now we know benefits the few at the expense of the many. And what we're attempting to do here with this commission, which we will do, is to reverse that equation so that by addressing corruption, we're going to benefit the many, not at the expense of anybody, but benefit the many. And as we've heard here from our outstanding presenters, that the co-benefits are extensive, they flow right through society. And as we also know that corruption affects all countries and is, as Dina mentioned, ubiquitous. And we look forward to working with you together to be able to address this challenge, which will make our world better, healthier, and stronger for all.